Dr. Laura Blaisdell has been doing for camps nationally, and how lucky are we to have her here in Maine with us and part of the team that's been helping figure out how to open camps this summer and be a resource to all Maine summer camps. So I can't thank you enough from the bottom of our hearts, Laura, for all you've done and for being here for us today, because I know this is a very unique summer and none of us have done this before. So the more wisdom we can get from you, the better. So thank you. And anyone who's on, we have about 50 people on right now. Some people have already submitted questions and Laura will be addressing those. If you have a question as Laura is talking, feel free to put it in the Q&A and I will be monitoring that and interjecting as we go through. If your question doesn't get answered during the period of time that Dr. Laura is talking, we'll try to address it at the end. Okay, you're on.
Okay, thank you everyone, and thank you for joining us today. I'm going to just briefly present some kind of broad concepts, and then I'm really interested in hearing questions from individuals because we know camps are so different, whether they're day camps or overnight camps. And so I really think it's important to know what questions you have. So as we've been preparing for camps to begin this year, there are a couple of resources I'm sure, and I hope that you found. The American Camp Association has put out a field guide for operations of camp this year. There was a short segment in that about the health center and about screening. And the development of a communicable disease plan, which I hope that you'll look towards. And then the state of Maine has put forward guidance for day and summer camps. So I think I'm just going to go ahead and start sharing my screen here. The questions that were submitted in advance I have included within this presentation. So I think first and foremost, camps need to be developing their own COVID 2020 communicable disease plan. So when you think about developing a communicable disease plan for your camp, it will be specific to your camp, whether it's a day camp or whether it's an overnight camp. And there are several aspects of the plan that involve the programming and cleaning, but also a large segment of that will be related to the health center. This communicable disease plan template comes from the Association of Camp Nurses, which is, the website is at the bottom, campnurse.org. All of their materials are free, and we appreciate so much Tracy Gaslin and Linda Urzeg, who have been tireless champions and leaders of camp nursing and have made this available to all of us. But sitting down and going through the motions of creating a communicable disease plan, and this template shows either before what camp should be planning before, during camp, including meeting with a team, how to identify illnesses, key health services and support needs, food services, communication plans, facilities, and then once, if you've had an outbreak, how to resolve and document, debrief, and update parents. So I really encourage anybody who's in health, camp health this summer, to look at the communicable disease plan templates that the ACN has put out, and attempt to create them and modify them for your camp. When we think about camp health centers, there is a vast variety of what a health center looks like. For a day camp, it could be a nurse on site who is there to triage kids either to home, to care, or to stay in camp. Or it can run the gamut of sometimes there's pseudo medical facilities on a camp an overnight camp that has doctors and nurses and infirmary beds, et cetera, et cetera. So I do realize we're speaking today to a wide variety of individuals, and hope that you will put into the Q&A box or the chat box, which Katrina is looking through, so that we can make sure that my recommendations are being tailored as much as possible to the camp health center that you're operating this summer. So, camps this summer should follow their standard and transmission-based precautions, particularly in the time of coronavirus. If you have a more extensive infirmary or health center, you may want to consider areas that you will be seeing people with potential coronavirus symptoms, and other areas where you will be managing the humdrum of camp health, which might be mosquito bites and scrapes and medication administration, et cetera. So there was a question about PPE. We will want health centers to have access to the full caveat of PPE, including respirator, face shields, gowns, and gloves. But a question will be coming up later as to how much of that is necessary. I'm going to talk in just a minute. Well, perhaps I'll just get to it now. The role of screening and testing. Then we'll talk a little bit about the COVID separation if you are in an overnight camp, and then just a couple of other things to think about, which are that maybe you might triage and treat in more open air clinics. As we know, ventilation is one of the mitigation factors in spread of coronavirus. And we will certainly talk a little bit about isolation and treatment. So when a question was asked about how frequently should campers be screened and what constitutes a positive screen. In terms of pre-arrival screening of campers and staff, what's considered a positive screen and what actions must a parent take in the event of a positive screen before a child is allowed to attend camp? So there are a lot of screeners available to us. The CDC has a coronavirus symptom testing and also a self-screener. Again, the Association of Camp Nurses has created this pre-screening form, which can be modified. Depending on your camp, whether you are a day camp and screening individuals daily, or an overnight camp where you might do a period of time of pre-screening, which is demonstrated here in this document, 14 days of pre-screening. Regardless, you should have a screening protocol that is documented, and it's not only, I think the most important aspect of a screening protocol this year is the symptom-based protocol. It is important to understand a little bit of exposure, which is demonstrated in this box, but increasingly the risk of travel has been changing because of the hotspots that are changing from moment to moment, frankly. So a positive screen would be anybody who has any of those positive symptoms that could be consistent with coronavirus. And then the action that your camp would take based on a positive screen will depend on your communicable disease plan that you make based on your camp. If it's a day camp, perhaps I would recommend that child not be admitted to camp that day, and asking the parents to bring that child to their PCP to be evaluated. And you might decide that you need either a note from a primary care provider that the child does not have symptoms that are consistent with coronavirus, or you might wait until you get a negative test result before that child might be allowed into camp. For those running overnight camps where kids are being pre-screened prior to coming onto the bus or prior to getting on any other form of travel to camp, it's really important to have a clear plan with parents about what will happen if campers have any sort of positive symptoms in the days leading up to camp. it's very important to communicate with parents the seriousness of putting a child on a bus if they have symptoms, and the need to communicate with camp about those symptoms and having them evaluated prior to camp. So can't say enough about the role of screening and the need to communicate clearly with parents this year, that a healthy camp begins at home, and you're trusting and relying on parents to accurately report symptoms and exposures. One other thing camps can do, you can ask kids to quarantine for 14 days, them and their families, or minimize their exposures to the degree practicable prior to coming to camp. I think that works best if you have longer single session camps as opposed to day camps that may have different families coming every week or every 2 weeks. But one can still ask families to act in a way that's socially responsible when they're sending their kids to camp. I just wanted to take a side to talk about testing. So testing for coronavirus has been, as my mentor in infectious disease and public health calls it, the Wild West. FDA had initial missteps in attempt to increase the amount of testing that was created. They allowed a different pathway for tests to be used through an emergency use authorization, which led to direct-to-consumer marketing without the typical validity testing that tests get prior to being approved by the FDA. So currently, most of the tests on the market are not FDA approved. They have an emergency use authorization, which is not the same as being FDA approved. Most tests, you should assume that most tests that are out there don't have clinical validity testing. They may have validity testing, and they certainly need to have validity testing within the lab to document their ability to diagnose or identify the subject that they're trying to test for, but the clinical utility of these tests has not been validated yet. There are two basic types of testing out there. There are diagnostic tests, and those could be the antigen, which is like the Abbott ID Now that you hear the White House using, or more commonly, the RT-PCR, which is the nasopharyngeal swab or the oral swab, or now we're seeing the use of saliva for this. The antigen tests are the ones, of course, that test for some sort of protein on the surface of the virus, and the PCR is looking for the genetic material of the virus itself. The PCR tends to be highly specific, meaning that there are not an incredible amount of false positives, so that if you get a positive PCR, we most likely can agree that that person has viral material from coronavirus, although there are false positives in PCR, although they are low. The other type of testing that's out there is what's called immunity testing or serology or antibody testing. These are the tests that the vast majority of us find very little utility in, although they are being offered. And why are they being offered if they don't have much utility? Because of that first bullet point of direct-to-consumer marketing without the validity testing that the FDA typically does. So when I've been looking at testing sites, I've been seeing, testing facilities that offer an immunity wristband, which to me is a marker of of a less trustworthy representation of what that company is able to bring you in terms of testing. Immunity at this point, and the serology or antibody of individuals is not confirmed to be diagnostic of having either immunity for coronavirus or even necessarily being exposed to coronavirus specifically. And so at this point, I don't see any utility in using immunity or serology or antibody testing in the camp setting. That might change as tests and immunity tests become more specific for what we know to be coronavirus. Another issue in testing is that most states, because of the availability of testing, have been only screening symptomatic individuals, or they've only been testing, symptomatic individuals, and often only symptomatic individuals in certain high risk or essential groups. So in Maine, you might have, if you practice in Maine, you might know that for a while we were in tier 1 testing, where we were testing healthcare providers who were positive, and long-term care facilities in which there were positive individuals. We have now expanded that so that we're testing anybody who's symptomatic, but there isn't a widespread recommendation at this time for mass screening of asymptomatic individuals. That is partly because the availability of testing is not there. We don't have the ability to do that number of tests, specifically because of the limiting supply chain of nasopharyngeal swabs or of the reagents that are needed for these tests. So one of the challenges in the camp setting is that I think we would very much like to test individuals before they come and know whether they're positive or negative. But the challenges of that are not being able to have access to those tests, and then the potential false negative rate of that test in an asymptomatic individual. That means that these tests are less sensitive in people who don't have symptoms, in picking up those who truly do have the disease. So Katrina, do you want to cut in? Yeah, go ahead. You cut in anytime.
Not to be surprised, we have a few questions on this topic of testing. I think you may have answered this one, but let's just review. If a camper has a positive antibody test at home and they develop a fever at camp, do we still need to take them in for a COVID test?
Yes.
I would think that would be a yes after what you just said. Yes.
That's correct. Yep. Okay. The antibody test is not to be, it doesn't have any clinical utility at this point. And so, yes, I would still recommend a formal nasopharyngeal RT-PCR.
Okay. And then somebody said, given 25 to 50% asymptomatic screen, is the 14-day symptom checker enough? So I guess the question is that a lot of people are asymptomatic, maybe carrying it without symptoms.
Yeah, that's a great question. And I think it gets to the concept that no communicable disease plan should be built on any one public health intervention. So it's not just built on screening, and it's not just built on testing if your camp decides to utilize testing, but it's also it's the layering of these public health interventions that give a strong communicable disease plan that makes it enough. So the other aspects of a communicable disease plan that one needs to think about is that oftentimes we think we can just test our way out of this problem, and we cannot. And we cannot screen our way out of the problem of spread of this virus either. That is why you see other recommendations that include these concentric circles of infection spread, which is that concept that we're going to break camp up into small households, and that we're going to limit the mixing between households, and we're going to keep households consistent over the camp program. If you're a day camp, the word pod has been something that people have liked more, that when your kids, your campers come in, they will be placed in a pod that will be consistent. It will be a small, consistent group of individuals that doesn't mix with other pods. So you have screening, you have testing, you have concentric circles of infection spread, you have physical distancing, we have face coverings, hand washing, decreased face touching, the role of quarantine or isolation, and early identification of cases. These are all of the public health mitigation measures that we use in the camp setting to prevent infection spread. A symptom screen or a negative test is unfortunately not going to be enough to hang our hat on this summer.
Right. And Pam Cobb has a comment/question. We have been in touch with Donna Guppy, field epidemiologist, Maine CDC, and Troy Cutler, ID preventionist. If we have an outbreak and have to test 50 people, they weren't sure how we would test large groups of people. Is there a chance drive-through testing could come to camp? Hard for them to commit to, but could there be a chance?
There's always a chance, Pam. I think now the state of Maine, although it doesn't have the ability to test asymptomatically, screening individuals, there has been a positive commitment to helping congregate settings like camps once they do have an outbreak to do testing. And so I hope that the state would be willing to come into camps, especially camps that are overnight camps that are trying to contain and remain in their bubble, so to speak. I would hope that the CDC would come in at that point. There are also commercial testing facilities that will send you the PCRs. You can swab everybody and send it back to the testing facility. So that is another option if the state doesn't feel compelled to help. But I do believe that the indications that I have had is that they'll help manage outbreaks.
Okay, that's it for now. You can keep on trucking.
Okay, great. Thanks. Please keep cutting me off, Katrina. Okay. Let's see. I am going to, let's see. Oh, so for the camper who tests positive, what considerations are necessary in determining whether to allow a symptomatic camper who tests positive to stay at camp as opposed to being sent home? So again, this is something that you should work out with your health center and your camp administration about how you're going to handle positive cases of coronavirus at camp. Certainly, if you are a day camp, I would highly, that person is going to be going home. You know, they will be isolated and sent home, and the pod that camper was in should potentially be considered to be quarantined, or also perhaps you consider at that point to ask that pod to stay home as well for the duration of the camp program. If for summer camps like my husband's, and for full disclosure, my husband is an owner director of an overnight residential camp, and I have been the medical director there for 20 years, and that's something that I think is a strength as a pediatrician, trying to offer assistance to other camps in their decisions to open and how to open safely. But in a summer camp like ours, there are a few considerations. How far away does the camper live? They might need to remain on camp until parents can come and pick them up. Parents this year have varying degrees of anxiety about their kids being at camp, and I certainly would say as a camp health staff and camp directors should be working with parents to help them achieve an outcome that they would desire. If they desire to come and get their kids, then certainly we would offer that to them. So the vast majority of camper age children are not highly symptomatic. There was a camp in Tennessee that opened with just their counselors and had a 30-person outbreak. Still trying to figure out. I don't think they put a lot of mitigation factors into play before opening that sort of counselor training. The full camp wasn't open yet, and the vast majority of those individuals were only mildly, if at all, symptomatic. So when you think about whether or not you want to, if you're an overnight camp and you want to keep campers at camp, one is to know the symptomatology that you can tolerate. Our health centers, I generally say camp health centers are not medical facilities. We're not designed to be that. We're an extension and a well-trained extension of the family home. So if there were symptoms that a camper or a staff developed while being ill at camp, you would certainly want to seek additional care if you were going to call the doctor or the nurse about those symptoms, you would want to consider moving that child to a higher level of care. The other consideration is your program duration. So campers who are diagnosed either by symptoms or by testing and found to be COVID positive need to isolate for 10 days, regardless of symptoms, 10 days from the first day of symptoms or the first positive test. So if your camp duration is 10 days, you might decide that your communicable disease plan is that any child who tests positive will be arranged to travel home in a non-public public transportation manner. So there are lots of different considerations, but hopefully that helps the person who asked that question with some of the considerations that they have. So moving on to illness management at camp, I think one of the things that's going to be really important for those of us in health centers is to understand our own needs for emotional and mental health support this summer, as well as that of the staff and the campers. One of the reasons that I do this, and I have committed myself to pediatrics and to opening camp this summer, is because of the emotional turmoil and unintended poor mental health outcomes that we're seeing in kids as they have been quarantined this spring. So, but that means that we also need to be aware that when they come to camp, they're going to require that the mental health and emotional support even more so. So having your attendance even up more so, and perhaps assigning somebody to be that person to provide that sort of counseling and support if possible. However one identifies case identification, we need to be in contact with parents about what will happen if their kid is ill. So will my kid go home, per our previous slide? How will I find out about that? How will I find out if my daughter's bunkmate turns positive? I think we need to strive for over communication and transparent communications with parents this summer. We have a couple of ways to identify cases, both symptoms and testing, and I believe there was a question about that. Given the mild nature of coronavirus and its symptomatology being that the children tend to be less febrile, have less coughing, they seem to have, at least in the Italian cohorts and the beginning of the United States cohorts, seem to have the same level of nausea, vomiting, and diarrhea. But which would be something that would pique your interest as a health camp director. If somebody said if they throw up, that would be something that would be an identifying symptom. I think it's important to have a high degree of suspicion this summer and isolate campers and staff early and test them if at all possible to identify whether or not they actually do have coronavirus. It's important to determine your triage plan, as we talked a little bit about in the other slide, whether you're going to be triaging into camp or you're going to be sending them home or to an outside facility. When thinking about your health center, you might want to think about how you're going to manage COVID or COVID-like symptoms. First of all, I didn't put this on here, but where is your isolation going to be? What are you going to do if you had 5 to 10 to 15 individuals who were relatively mild in symptoms? Where would you have them sleep? Because they are not going to be able to sleep in their bunks. They're going to need to be isolated. How will you manage your health staff? Will you have certain health staff that are designated to the care and well-being of that group? What will you do once you do the symptom-based management, fever, cough, nausea, vomiting, diarrhea? And what are you going to be your gating mechanisms to seek higher levels of care? A lot of parents and a lot of us have heard about the multi-inflammatory system of childhood that has been identified as a potential and likely sequelae of coronavirus. It tends to be a late sequelae, and it's very important to have our antennas up that if disease isn't resolving as we think it should, that we look at those symptoms of MISC, which include a prolonged fever of more than 3 days or any sort of shock-like symptoms, and seek higher care immediately. Additionally, you should challenge your camp administrators to help you as a health center identify when children are feeling better, which is often very quickly, or they may be asymptomatic. What is going to be their program while they're waiting? It's probably going to be important for camps to consider what I've called a shadow program. And in the 2009, during H1N1, this was what a lot of camps did. Our camp did as well, is that we had a separate camp program for kids who were convalescing or who had been symptomatic, reminding ourselves that there are 10 days of isolation before we can send kids back into the camp program. So what will happen with those kids, and whose responsibility will it be for that program if the health center staff needs to once again attend to taking care of the health and well-being of camp. And so that's an important discussion to have as part of your communicable disease plan. Moving on to thinking about the potentially exposed. So as I spoke earlier about the concentric circles of infection spread, this bullet is why that is so important to consider as a backbone of infectious disease management at camp this summer. So when when the health center identifies that somebody is positive for coronavirus, we'll do contact tracing, and I use air quotes because contact tracing is a very it's a skill that one needs to be trained in, but we always are doing it in camp anyway. Who was Johnny sitting with? Who was in his tent? Who's in his bunk? Who was he exposed to? If we develop a camp program in terms of households or pods with physical distancing between pods and facial coverings when physical distancing is not practicable, then when we think about the potentially exposed, we go back to that household and that pod, and you will need to determine what will you do in terms of surveillance and quarantine of that group of individuals. If it's an overnight camp, you'll want to quarantine that group, increase the mitigation measures in terms of physical distancing, facial coverings, et cetera, increase the surveillance of that group through screenings. There is a testing strategy in the long-term care facilities of testing at day 1 and 10 of people who are potentially exposed. It's going to depend on the availability of these things for your camp. If you are a day camp, I think it's probably best in this scenario that we're living in to consider either further quarantining that pod off, or consider letting the families know that that group has been exposed and you're going to ask that group to stay home, and perhaps they can come back when they've had negative testing. Quarantine is 14 days for that group. And of course, cleaning and disinfection is going to be important. Cleaning is the physical cleaning of the dirt and things that you see. Disinfection is, the removal of infectious particles from the object of concern. The American Camp Association Field Guide and the Environmental Health and Engineering, which is the independent group that they hired to help them draft the field guide, have more pages on cleaning and disinfecting than you would ever care to read, but I will direct you there when you think of cleaning and disinfecting. Katrina.
I'm back.
Great.
Questions on
How are we doing?
on illness management. So most guidance has camps starting cohorts in small numbers, and then after 14 days make an assessment for increasing the numbers in the cohorts. What should we be basing that decision on, and any advice for how much larger we can make the cohorts?
Yeah, it's a really important question, and one that I can give kind of like bumper guidance to, but I think we're all going to be very closely watching our camp health in those first 14 days, and whether screening is what you're doing or whether screening and testing is what you're doing. We're going to be looking at that data and deciding how much can we let up. Given the fact that the contagiousness of coronavirus seems to be a little bit more than flu, certainly less than something like measles. That's when I think about, how many cases or case definitions would I have in camp before I would allow increased mixing. I think I would want to see that there was no increasing in cases in camp. And certainly I would want to feel that I felt very confident about my ability to control cases if they did pop up after mixing. So for instance, if you had a household of 10 individuals that represented 2 bunks, that household might be able to, after 14 days and a stable health situation at camp, might be able to intermix with other households in their age group, for instance, so that you continue that next concentric circle is a little bit larger, but it's not the entire camp. You might decide also when, if it's day 15 and you're just about to make that decision to increase your household to a larger cohort, which I'll call a neighborhood, you might decide that for those first couple of days, that mixing will happen outdoors. We know that ventilation and sunshine at coronavirus seems to be denatured with sunshine from some recent studies, and we know the ventilation of outdoor activities is quite good. So you might decide that the first couple of days you're going to choose programming that is lower risk in terms of contact intensity and risk of contact spread. So something that we're going to certainly be watching, and just realize that you may have to put the genie back in the bottle. I mean, this is going to be, I think we're going to see this as a society as cases ebb and flow. We're going to need to have very nimble policies and interventions that we can put into place that don't completely shut everything down and send us into 100% isolation, but allows us to put the genie back in the bottle, like moving from one concentric circle back down to a household, for instance.
Great, thank you. We have some other questions that are also back to some testing things.
Yeah.
Do you have suggestions for commercial vendors that will provide swabs and process by mail?
I can certainly put together a list of people that I've heard. I think a lot of camp directors have been sharing the various vendors that have come to them. But certainly I can get that to you, Katrina. Maybe you can send that out as a list of potential vendors. I really want to be careful to say that none of these vendors has been vetted, and by vetted I mean FDA approved, and I'm very suspicious of all commercial vendors at this point. So
yeah. Back to the staff training outbreak that you mentioned, what do you recommend we ask of staff prior to arriving on property?
I think that staff, I would certainly ask them the same things. I would ask them to minimize their exposures. You could ask them to do pre-screening symptoms if you wanted to. I think it's important for staff to think about how they're getting to camp, and you could provide some guidelines for safest travel to camp, providing them guidelines for hand washing and physical distancing and face coverings on the way to camp. And having counselors aware that their exposures prior to camp are really important for a healthy camp experience. Oftentimes when I explain to people that if they get ill, they're going to have to be isolated for 10 days, I think that is a big motivator for individuals to comply with those sorts of more quarantine recommendations. I think people are starting to understand that we have a bubble, right? And our bubble can include our household, and it might include a couple other friends that follow the same public health interventions that you do, that you mask and face cover. And I think it's important that counselors be made aware of how serious it is that they follow those recommendations.
And I know that we're considering, or we're planning on using the same kind of pre-screening with our staff that we are with our campers, where they're checking their own symptoms. So I don't know if that's what commonly being done, but we're certainly looking at it.
Yeah.
Another question. So Bobby Strauss asked, does this mean that lab draw serology IgG antibody testing does not currently offer clinically significant information? I think that's what you said.
It allows us to have some information, but there's no information from it that would let any reputable medical group tell you that that means that you are immune from coronavirus and you will not get the disease again. The problem being twofold, at least. One is that we don't know if having the coronavirus confers immunity, and which it probably does, but for how long? And we're hopeful that it does, but scientists are exceedingly boring in the fact that we won't tell you 100% that it does until we have proof, and that's really frustrating. that we won't go there. But I think we're getting to the point where we're going to be able to talk a little bit more about what having the disease does in terms of your immunity. The second thing is that coronavirus, if we remember, is a common cold. It's a common cold that linked with the SARS virus. And so many of us have been exposed to various coronaviruses in the past that didn't have that SARS component linked to it, that mutation. And so a lot of us have circulating antibodies to these common colds. So when you get a serology test, it might be picking up the runny nose that you had last fall and not picking up maybe what you thought was maybe the coronavirus when you had a sore throat in January.
So more on that in the future.
Yes, hopefully. I really hope that we get to a point where we can have a test that tells who's been exposed, because we haven't had the capability in this country, or many countries, but certainly this country, to identify who's actually ill with a diagnostic test.
Okay, if we have a documented case, assuming we cannot test all of the exposed on day one, how long should we wait? 2 to 5 days? Is there any consensus on when to screen the entire exposed cabin households?
It's a great question. So if you have a case, we think that the vast majority of individuals will develop at least PCR detectable viral RNA particles by 5 days. That is so, but it's a very squishy recommendation. Your true positives will go up and your false negatives will go down every day that you wait. And you could also do it based on symptoms. You could wait until somebody has their very first symptom, which will increases your pre-test probability that your test is going to be true. And so that's one way to do it. For instance, if campers are traveling on day 0 of camp and you want to do a testing strategy in your camp to collect the most likely number of kids who are turning positive from their potential exposures while traveling, I would say somewhere in the day 5 or 6 range would be like, the most bang for your buck, meaning you're going to catch as many of the potential positives as you can, with kind of balancing the false negatives that that you're going to miss by not waiting until testing until symptoms, or waiting until testing until day 10. But it's that awareness of what you're everything's a trade-off of when we decide to test and what we test with. And so it's knowing what you're trading off. So if you say you decide to test at them all on day 3, well, that there's some false negatives from that test. And you're going to have to continue active symptom surveillance and the quarantining and the face coverings and the physical distancing. You just have to do all those things. And it goes back to that, that comment of that no one mitigation measure is going to get us out of this conundrum of having a robust plan.
Great. Thank you. Apparently, Laura Ordway shares CVS pharmacies in Maine are now offering COVID-19 drive-through testing. What category of testing is this? PCR or serology? And she said, sorry if I got those wrong.
No, good, Laura. Laura gets an honorable degree now. She's sat on enough of these Zoom calls. I believe CVS, and don't quote me, and I will definitely check on this, Laura, afterwards, but I believe CVS has a relationship with Quest, and they are doing RT-PCRs. And so I believe that is what CVS is doing. The turnaround time for that, I'm not clear on, and that's if one can find a good, reputable vendor to do PCR, then the next question is how long does it take to get your result back? 5 days of camp programming is a long, long time, and that's a lot of exposures. So, we know that, the only rapid tests we have are the ID Now, which is an antigen test, which has, higher degrees of false negative tests than we had hoped. But so we know that we're going to have to wait some period of time, but I would be interested in, if you are looking at the CVS as a potential drive-through, I don't know if they'll take a bus or a van, but, asking them how long the turnaround time is.
And on that testing note again, do we have information on the sensitivity of oral or salivary PCR swab versus the nasopharyngeal ones?
Good, Katrina. All right, you get an honorary degree too. There is some testing out of Yale that looked at NP swab versus saliva. And it looks like saliva in that testing from Yale was just a bit more sensitive. There is more specimen, so to speak, in terms of saliva. The testing has not been validated in children, which is a hard aspect of using the Rutgers test, which is the saliva, in-home saliva testing. But it does show promise that saliva may collect more viral genetic material than a nasopharyngeal swab, which any of us who've conducted a nasopharyngeal swab know that it's highly technique independent. That if there has to be tears at the end in order to get a good swab. And so I look forward to getting, kind of what I'm looking for is kind of the clinical sensitivity of the saliva tests and whether or not there's a lot of false negatives from that test in asymptomatic individuals. But it looks like saliva is going to be a good option, which I frankly, as a public health practitioner, I'm excited about, because it means that we don't have to have swabs as a rate limiting supply chain agent.
Great. Couple questions on what about the implications for staff members that would need to come into contact with a positive camper?
Yeah, so are you reading that, Katrina, as probably like in shadow camp or something like that?
I'm guessing like somebody who's got to take responsibility for a camper who's testing positive, right? So
Right. So, the most ideal thing would be that that I'm not even going to say that. If a counselor were to become ill, and develop, you have a positive corona test and hopefully have very little symptoms and was better, that would be an ideal person to consider whether or not they would host a shadow camp. Without that individual, the health staff, as people who are used to using those sort of standard and transmission-based precautions, would be the individuals that I would want involved in interacting with a camper. There was a question, I think, about aerosol generating procedures and N95 masks, and I think the camp setting doesn't have strong guidelines about the use of N95 masks and kind of the full getup, the masks, the surgical mask over the N95, the face shield, the gloves, the gown. But each camp health practitioner needs to make their own decision about their, who's in front of them, whether they're coughing and doing aerosolizing, generating, activities, and how protected the health staff wants to be based on that risk. If a camper is convalescing outside who has been positive, then I might not choose to don full PPE in order to bring them their medications or take their temperature. If they were actively coughing, I certainly would. And I might decide to do something in between, which includes, a face shield and a N95 mask when I'm around individuals who have been demonstrated as positive. So probably not as helpful, because it's not kind of like if this, then do this. But the camp setting tends to be a little bit more crossing each bridge as they come to it and assessing the risks of each camper.
Right. And any suggestions on the frequency of screening that we should be doing during camp sessions at overnight camps?
I would say it's, I know that it's a pain when thinking about screening. It's not only logistically challenging. I realize that we don't want to hyper-focus campers on their health and well-being every single day. I think any of us could make our own children neurotic if we said, "Are you sure you don't have a fever? Are you sure? Are you sure? Are you sure? Are you sure?" That is not a mentally health-friendly activity either. So I think that it's reasonable to think about screening every day, making it part of whether it be your bunk inspection, or whether, we do tick check. Most of us do some sort of tick check every day. Most of us do some sort of inspection every day. We make sure that the kids brush their teeth every day. So figuring out how to embed it into a more natural everyday activity, I think, is important. Whether you might decide to do it, before breakfast, and campers are in their cohorts and you screen them as they go into breakfast. But I do think that there should be probably some sort of daily screen at this year. Perhaps next year we'll realize that it didn't help as a mitigation measure as much as we hoped it would.
And would you, I know we do tick checks, it's the staff that are doing those. Are you suggesting that health center staff train cabin staff to do those everyday screening?
I think health center staff are going to need that. If we're going to do robust screening on a daily basis or even twice a day, I think the health staff do need to spend some time in staff training.
Uh-oh. Ron? Laura's frozen. One moment, please, everybody. We're just having some technical difficulties, or maybe I'm having technical difficulties. I can't hear you. Sorry, everybody. We're having some internet difficulties. Just bear with us. Okay.
Okay, good. Oh, I'll have to figure which one of my kids is like Netflix streaming.
All right. So I forget where we were, but do you have some more slides to go over? Do you want to finish your slides and then we can ask any of the final questions?
Sure. Let me share my screen again.
One thing that somebody just wrote, and I think I can even answer it, the question was, doesn't camp need to close if there's an outbreak of 3+ confirmed cases, full stop, per CDC guidelines? The Maine state can close us at any time, and that is in the Maine state guidelines, my understanding, but it's not the intent necessarily that they would close us. That's my read of that. Is that right, Dr. Laura?
Yes. So the number 3 cases comes from the NERD epidemiologist definition of what an outbreak is. So that's what we call an outbreak, just like we call a fever 100.4. But a fever, most lay people don't call a fever 100.4, and most people call an outbreak probably something bigger than 3 cases. But that's what state epidemiologists will call an outbreak. The state of Maine has historically been very respectful of camps' ability to handle illness. And they're quite complimentary about Maine camps, particularly after coming through the H1N1 season and seeing how camps were so responsive and creative in mitigating the infection in their camps that summer. So I don't have any indication that the state is interested in shutting down camps if they have 4 or 5 or 6 cases. I do think that for all of us, and particularly those of us in health center, if we were upwards of 20, 30, 40% of our campers and staff who were ill and testing positive, would be starting to look for what is the most reasonable next public health step, and that might involve stopping the camp program. So, but that there is not an interest at this point to shut down camps if they have, a certain number of cases.
Right. Onto your slide.
So I'm going to, okay. So this was a question, let me just see, I lost my place in terms of where I was. Yeah, okay, so we're going to go with this. This is more of a programming question and a cleaning. So if an asymptomatic individual playing kickball touches their face while playing the game and then touches or catches the ball, and others also touch the ball throughout the game, say this camper is with their family and still in their initial 14-day quarantine time at camp, would this type of contact with equipment potentially transmit the virus? So we know that coronavirus is primarily a respiratorily spread disease. And we do know that that the disease can live on fomites, like balls or doorknobs, etc. But we don't see massive transmission by individuals who have touched a public or a high frequently used area and touched their face. That's not tending to be a spread pathway that we're highly concerned about. That being said, washing your hands and not touching your face are age-old, evidence-based health safety measures that work, and we know they work. So when in this scenario and in all camp programming, I have been recommending what I call scrub in, scrub out type of activity. So before you go playing kickball, you sanitize or wash your hands, then you play. If you see some kid, doing what kids do, either picking their nose or sucking on their hand, we gently and respectfully pull the kid aside and say, let's use a little hand sanitizer and clean that up just as we would with our own kids. And then when we're done with the game, we do our cheer and we also wash our hands and we make it somewhat fun. So yes, while there's potential that these sorts of things, fomites could transmit the virus, it certainly is not as concerning as being in close proximity with somebody for a long duration and expelling air on an individual. We do know that singing, shouting, these sorts of activities do cause forceful expiration of respiratory droplets, and they can go up to 13 feet. And so, the 6 feet measure is good for general activity, but you'll see guidance coming out about gyms or about yelling or singing that we know that we need to have an even larger physical distance from individuals when that sort of activity is happening. And then this is the last question that came in, and then Katrina, I'll hand it back to you to see if other people have questions. When a camper presents with COVID symptoms, of which there are many, what will be your threshold for testing and isolation? As a camp as a nurse at a camp without on-site physician for support, I'm trying to determine who to take for testing and when. Excellent question. Camper with fever, loss of cough, smell is straightforward, but a camper with a headache and a sore throat is less so. Yes, this is an excellent question. And I think the, this is the $1,000,000 question. I think I'm going to try to be a little bit more conservative and try to find a symptomatic testing turnaround strategy for our camp that will give me an opportunity to ask that camper to stay with me until I can get a negative test back. I think, if it's obvious that the eyes are red, they're weepy, they're itchy, they have, what we call the allergic shiner, that sort of wrinkle on their nose that they have from itching their nose so much, and it sort of definitely looks like allergy, I probably wouldn't pull them aside. You might also think about, headache and sore throat. We have a lot of enteroviruses that happen in the summer that have, they'll have like petechiae in the back of the throat on the soft palate. You might think about whether or not you might have rapid strep tests available to do those on site so you can rule those things out. But I think in general, I'm probably going to be a little bit more cautious, particularly in those first 14 days of camp before I've done any sort of testing or monitoring of symptoms of other individuals. I might pull them into isolation and test them. Is there a scenario in which you can imagine running camp without access to diagnostic testing? So when I started this, journey, when we started this journey, my instinct was that we weren't going to have any access to testing, given the supply chain issues and the late start gate that we had in the US in generating tests. So yes, I think that you could do all of those other mitigation, active screening. You may decide that you're going to screen twice a day. You're going to be very strict with your cohorts. You're going to make sure that they're physically distanced and they're consistent over time. You're going to have campers be wearing face coverings whenever possible when they're unable to physically distance. If I wasn't doing a testing strategy in camp, I think I would really ensure that campers were quarantined prior to coming to camp. You might choose travel to camp options that are a little bit more conservative, like chartering a bus or having parents direct to camp deliver kids in their individual family car. So you might want to beef up some of the other public health mitigation strategies, diagnostic testing. Now, of course, all of us know, and I know as well, that the asymptomatic carriers of this disease, particularly in children, is the worrisome aspect of not having a test. And we also know that these public health mitigation measures work in terms of infectious and communicable diseases. And so I do think that there's a way to do it without testing. How are you going to get diagnostic testing done at my camp? So there's a couple of different things that we're going to do at our camp. We're going to ask parents to have their children screened by their primary care provider for testing 5 days prior to camp. Then we are looking at a couple of different options for testing, whether that be bringing them to our local hospital for testing, whether that be contracting with a commercial vendor. The state of Maine is always changing, and I think they really want a way for tourism to happen. So I'm not sure about whether the state of Maine would be a source of testing for camp. And at that point, after getting the PCP, PCR, sorry for all the acronyms, but you're healthcare individuals, so you're used to them. After getting the results of the PCR from home, perhaps doing another test 5 or 6 days in at camp and really doing that sort of all those mitigation measures, including surveillance. I hope that we'll be able to get a good handle on next steps, and hopefully we won't be needing to do symptomatic screening or symptomatic testing, excuse me.
So just to clarify on that, Laura, you're feeling that your camp families are going to be able to go to their primary care physicians and request a diagnostic test?
I'm encouraging them to try. I've written a letter that parents can bring to their primary care provider explaining why this child who is asymptomatic is at higher risk because they are living in a congregate setting this summer, and hoping that my urging will, in addition to PCP's understanding the need for these kids to be healthy when they arrive at camp, that they will do the testing.
Great, thank you. A couple more questions that are coming in the chat. Do you have a moment to answer those, Laura?
Yeah, absolutely. Yep.
Along the lines of your excellent statement, layering of safety, Winona, this is Laura Ordway again, is thinking of using the CVS drive-through options only for staff and campers who, for some reason outside of their control, couldn't arrive on opening day. We're not offering or requiring screening testing at this time, but might use the drive-through testing for these special late arrival cases and then isolate them at camp until the test comes back. What do you think of that possibility?
Yeah, I think that's a great possibility, and definitely goes with that kind of concept of that testing isn't some sort of golden trident. It's to be added on top, and I think that Laura, I would just say I would really want to know the turnaround time for that test. And I know that if they are working with Quest, I think Quest is doing well in terms of their turnaround times. But as CVS testing strategies ramp up, I would want you to have a backup plan as well. If they, for some reason, ran out of reagent, or that's the problem about having only one horse in the race. Is the reagent and the limited swabs and reagents. But I think that's it's a very strong strategy.
If your health staff is immunocompromised as per CDC list, and you get a positive case in your camp, should that nurse, or I guess really if you have other staff in that same scenario, should they be leaving camp, or what's your recommendation on that?
I have a couple of thoughts on that. One, I really hesitate as an employer getting into, the privacy issues of a person's health. I think that camp directors should be having a conversation with all staff this summer about whether they feel that they can be at camp in a healthy way, and what would happen if camp were to have an outbreak or an exposure. What would happen if that individual did have an exposure to coronavirus? We need to be planning for that, and this question is doing that. I highly encourage individuals to speak with their doctors, staff members, and asking camp directors to say, could you please let me know what your doctor thinks of your health condition and what should be done if you're exposed at camp. Generally, I think we'll know a lot more about the health of all of our camps, once we start and we understand. But, if there was a ramping up of case numbers and I had health individuals in my camp whose health I was concerned about in terms of staff, I probably would move them off the front lines while we try to contain this illness, or in camp. So I think for as a pediatrician, it might be awkward to say, but I'm much more worried about those older individuals and other individuals with health risks that are going to be at camp this summer. And I highly recommend having those hard conversations with individuals about this might not be the summer for them to be at camp. And as I say to parents as well, who are feeling very anxious for whatever reason, whether it be the health of their kid, or just because it's an anxiety producing existence currently, that it might not be the year for everybody to be at camp.
Yeah. Laura, can you tell us the reference you used in determining your policy for the negative PCR 5 days prior to arrival at camp? Is there a reference to that?
I don't have, there isn't a, unfortunately, I wish that we had testing, a randomized controlled trial testing that would allow that to, for me to point to a reference. I think I look at the average days to symptoms in children and adults, and I can try to find that's information I've garnered over thousands of hours of Zoom calls with the American Academy of Pediatrics. But I can try to find some data on that. I know a lot of businesses that are doing screening will do it on day 1 and day 10 if they're doing testing. They'll do one at day 1, and then they'll do another at day 10 to 14. So I think I chose day 5 because I will have a PCR 5 days prior to camp, and then 5 days into camp will be 10 days after that initial test, and a likelihood of catching kids who were exposed while they were traveling. So it's a little magic, to be sure, but I can try to find some references. It'll be a good exercise for me to go back and find those references, so I can try to find them.
Can you speak to the risk of campers with asthma attending camp?
Yeah. Interestingly, data from New York, and this is from a New York Times article, showed that kids weren't really showing up in urgent care or hospitals with asthma. In fact, kids aren't really showing up at urgent cares or at hospitals at all, with the exception of these rare events like the multi-inflammatory syndrome. We haven't seen that sort of we haven't seen asthma be an incredible risk. So I think for kids with mild to moderate asthma, I think camp should be a possibility for them. Of course, that's a conversation that they should have with their pulmonologist or their pediatrician, because even if you have mild asthma, that just might be that kid that just goes from 0 to tank in no time, and you've seen it happen for 4 winters in a row. So that's why I think on the good note, I don't think that asthma or type 1 diabetes or a lot of well-controlled diseases seem to be a reason to not have kids at camp this summer. On the flip side, I would caution each of us to ask the child's pediatrician to weigh in on that, and it really helps the parents come to peace about their decision as well when their trusted pediatrician or primary care provider tells them what they think.
Great. If staff arrive for a 14-day quarantine before campers arrive and a staff becomes positive on day 7, does the 14-day count restart for the staff, for the rest of the staff? Does the camp delay opening?
Right. So herein lies the layering of public health measures, right? So the question, I think, if I was going to go in and do sort of an analysis of that situation, I would say, well, who has that counselor been with in the last 7 days? How much exposure do I have? If the exposure is great, I might just decide to do a screening of all staff, in 5 to 7 days to make sure that I catch everyone. I think that, what has happened at this summer camp in Tennessee was that they did just delay camp another week so that they could make sure that they understood what was happening in their counselors. But this is why when counselors come, they should also be cohorted into small groups. They should be physically distanced. You should start playing games in training that have to do with, physical distancing and face coverings. And, we've been playing with this idea of assigning them to a color when they come. And every time we see each other, we hold up our color and we say, oh, Laura, you're yellow. I'm blue. We're not from the same household. That means that I can't come closer to you than 6 feet, and I need to put on my mask if I want to hug you. So not that we're, encouraging people to hug each other this year, but maybe an elbow bump. So I think one needs to think about that situation and think about what else are they going to put into place to make sure that situation, if they were to get there, doesn't spread rapidly throughout the rest of the counselor staff.
Great. I think we've just about exhausted. One big question that came at the very beginning, at what point would you recommend we rethink opening camp and cancel camp? I mean, that's kind of the elephant in the room, right?
Right. And, as I said about, it's not the place for all people to be at camp, and it's not the place for all campers to be at camp this summer. It's not the season for all camps to open either this summer. And lest my attempts to allow camps to open safely be misconstrued as a acknowledgement that or a rallying cry that all camps open. It's not. What I would say is that you should look at the mitigation measures that we've talked about and look at your camp program and think about whether or not you're going to be able to pivot and turn and put those into place. If you're not, it's fine. It's no shame to say I just can't do that. Additionally, you may have a majority of your staff that has high health risks, and you're just exceedingly worried about that. So I think that it's not either. It's a very personal decision for each camp, and it's based on a lot of different things. And I have felt that camps who have closed, I think that they've done it in a very respectful and responsible way. But I think it is important for people to realize this isn't about whether we can, that it's unsafe to open camp or that it's unethical to open camp. It's not either one of those pejorative comments. It's a commentary. It's about whether or not camps who do open can be very responsible about employing the mitigation measures that we have to decrease spread, and be responsive and nimble and change if mitigation measures are working or if they're not.
Perfect answer. One last question. So Pam's understanding was that masks were not a substitute for social distancing. Can you get closer than 6 feet with a mask? Or a facial?
So facial coverings, just to remind us as a level setting, that facial coverings is I protect you, you protect me, right? So they're not me protecting me, unless you're in the health staff, which is wearing an N95 or a surgical mask, which we're not recommending that people wear N95s or surgical masks. Those are reserved for people in the healthcare facilities or essential workers. So face coverings can be worn, particularly if people are asymptomatic. So for instance, in a program, say I'm teaching archery, and I am the archery teacher and my campers are 6 feet away, and I say, today we're going to be working on this. I want you to do this, and I want you to do this, and I want you to do this. Okay, go ahead. I blow the whistle. They start doing their shooting, and a kid is really struggling, and clearly I need to go over there and help them, get that elbow up and that arm straight. That's when we would find a way in our camp to communicate mask up or some other word that means that, where the camper would put down their bow, they would put on their mask, they would pull up their buff, whichever it is that you've chosen to use at your camp, and the counselor would also put on their buff, and then the counselor would do their teaching, and then they would move away. I think when we think about risk of infection, it's contact proximity times duration, right? So a close interaction that's short in nature is going to be lower risk, and it's going to be particularly lower risk if we're both wearing face coverings that fit appropriately. So I do think that there is room for those closer contact teaching, but to be aware that we're not going to be pig piling on top of each other like we normally do at camp. And maybe we're not going to be doing those programming aspects of camp that require us to be in close contact for a long duration. I mean, I look at the Gaga pit and I think, oh, it is not going to be fun to have 3 kids in the Gaga pit this year, but we might just not be able to do Gaga this year.
Yeah. I'm going to end with this comment. After I say I'll end with this comment, and then I'll review a few things. But thank you so much for taking the time to do this, Laura, for the larger camp community. You've been so generous with your time and expertise. We are profoundly grateful, and I think that sums up how we are all feeling. If I can just remind you, if it's possible to share with us any information on vendor or sourcing of the swabs, I think was a question.
Okay.
That would be great. And if you're willing to share your letter to family physicians, there was a question about that. And somebody wants to know if you're available for offline email questions. I think we should direct any questions to Ron if we have any follow-up questions, and we'll determine if we can get those answers for you. And there was one last question about singing at camp that has been, I think you addressed that to some degree, Laura, that respiratory droplets can fly up to 13 feet with singing and shouting. And I know a lot of camps have been talking about doing those kinds of things in different ways, whether, you know, everybody's in a large circle separated and then they all turn around and face the other direction, so they're not facing each other, was something that I had heard. So we definitely have to look at singing and shouting in different ways this summer. Would you agree?
Yeah, definitely. There's ways to do it. You can do it with a mask, but or a face covering. It's not as fun to shout through a face covering. But I think we need to be realizing that is a higher risk activity that you want to do once you really understand your health at your camp.
Perfect.
Kat?
Yeah.
During this webinar, I have been getting questions about when and how will people be able to access this webinar. And so I will let everyone know that as soon as I get it back from Zoom and convert it, it will be up on our private Facebook group. It will be in the Next Hall Monitor, and it will also be listed on our website in the COVID-19 private section. And if you've forgotten, the password is 100 lanyards, plural. And I will also include in the Hall Monitor and on the website any information that Dr. Blaisdell gives us.
Great. Well, once again, we're so appreciative of all your expertise, your combination of understanding of the science and working with children in pediatrics, but also working with kids in camp. It makes you so unique in your contributions to us. So thank you very much, Laura. We appreciate it.
Thank you, Laura.
I'm grateful for the people on the call and grateful that we're attempting to provide this opportunity for kids this summer. So thank you.
All right. We will
Stay
end.
healthy, everyone.